Today I'm going to talk with you about the evidence present for using mirror therapy as an intervention to assist with motor function following a stroke. Mirror therapy involves placing a mirror in the mid-sagittal plane reflecting the non-paretic limb, which creates the illusion of movement of the paretic side. By mirror therapy. In 2008, the World Health Organization stated that stroke is one of the world's leading causes of long-term disability. This, coupled with the fact that around 80% of stroke survivors will experience some form of upper or lower limb impairment, shows that this is an area where rehabilitation is of utmost importance. Whilst mirror therapy is traditionally used when working with individuals with phantom limb pain following an amputation, there has been evidence to suggest its usefulness when working with individuals recovering from stroke. As occupational therapists, we assist others to achieve the occupations that are meaningful to them and that they need, want, or are expected to do. Given that limb paresis can often inhibit a person's ability to do these occupations, there is a clear role for us in this area, and mirror therapy may provide another avenue for us to explore. Mirror therapy has been used in stroke therapy since the 1990s. However, it is still relatively new in terms of a mainstream intervention and the evidence-based research. Essentially, it is a form of sensory motor training that focuses on visual input. This form of intervention is seen as being potentially useful in assisting those recovering from stroke, as many of the current interventions require some degree of voluntary movement, and this may not be possible for someone with severe paresis. Therefore, this type of intervention that uses different paths, such as visual input, to achieve function, may have advantages as it may increase corticomuscular excitability and stimulate motor recovery. Whilst there are no definitive answers, the evidence looks promising. The search strategy I used to find my 3 pieces of evidence is outlined here. I focused on electronic databases that represented work from the health sciences. I tried both broad and specific search terms and used search dates from 2008 till present. However, the majority of the randomized controlled trials I found were within the last 4 years. I decided on a Cochrane review as this represented the highest form of evidence. I also collected 2 randomized controlled trials, one of which was the most recent that I could find that directly related to mirror therapy and improving motor function following stroke, which was Wu et al. And the other randomized controlled trial I found was one that represented a strong piece of evidence, which was Tiem et al. As mentioned previously, I used 1 systematic review, which is level 1 evidence, and 2 randomized controlled trials, which is level 2 evidence. The systematic review represented a high quality evidence. It included an extensive search of the literature, electronic and paper. The authors also contacted researchers to gain further insight into their work where needed, and they also looked into research that was currently being conducted at the time of the review. The inclusion and exclusion criteria were well reported. While it was a bit broad, as it included studies that compared mirror therapy to a number of different interventions, not just one particular control or no therapy, it did answer the review's aim, which was to summarize the effectiveness of mirror therapy overall in relation to stroke. In this light, the criteria seemed justified. The conclusions reached by the authors seemed reasonable, and they also addressed the implications of practice and further research. The first RCT, TM, received an 8 out of 10 on the Pedro scale, only failing to blind the subjects and the therapists. This issue was one that was common with studies in this area, as it is an intervention that requires active involvement from the client. The overall quality of this paper was high, with potential bias mentioned later on. The second randomized controlled trial, Wu et al., received 6 out of 10 on the Pedro scale. While still an randomized controlled trial, it does not have the same quality rating as the other RCT looked at here. This paper also did not blind the subjects or the therapists, and they also did not apply an intention to treat analysis, and there was poor follow-up with less than 85% of participants taking part in the final analysis. Here are listed the potential forms of bias for the research. As you can see, the randomized controlled trials did not blind the subject and the therapists, which means that bias may have occurred as the subjects knew what therapy they were receiving. Across the board, it was noted that research in this area has poor sample sizes, which reduces the power of the study. Tiem et al. Experienced a dropout rate of 20%, although they did include an intention to treat analysis, whilst Wu did not. Which puts a question mark on their results, as the groups were not compared as they were originally randomized. Finally, the systematic review was only able to find 14 studies that met their inclusion and exclusion criteria. As can be seen here, one of the authors, Tiem, was also involved in other research. This was managed by the authors of the systematic review by removing him from any analysis of research that he was involved in. However, there may still be some bias. So what does the evidence tell us? Here I have summarized the conclusions of the studies looked at in this report. The Cochrane review concluded that mirror therapy improved motor function in individuals when compared to a sham therapy, which was not another evidence-based therapy. They also found that mirror therapy may improve other outcomes such as activity of daily living and pain, but only in patients with complex regional pain syndrome. This review also reported that there was evidence that the results from the mirror therapy interventions were still present 6 months post-intervention, and that no study had reported negative effects related to this therapy. The first randomized controlled trial, Tiem et al., found no difference whether mirror therapy was conducted in a group or individually, and there were also found no difference in results between mirror therapy and the control therapy. The only area where mirror therapy received significantly better results was in relation to visuospatial neglect, which was a secondary outcome. Wu et al., on the other hand, did find that mirror therapy significantly increased motor function compared to their control therapy. They also found that reaction times were decreased in the mirror therapy group. However, unlike the Cochrane review, they did not find any improvement in activities of daily living. However, this was a self-reported measure relying on a person's self-perception. So what are the lessons learned? Well, from this evidence, it can be concluded that mirror therapy may improve motor function following stroke. More positive results were seen in studies where the therapy was used more regularly and with greater intensity. Results were often skewed by the severity of the paresis, with participants with mild to moderate paresis having a better prognosis for improving motor function. As well as this, there is some evidence to suggest that mirror therapy can assist with improving activities of daily living, reduce pain, and reduce visuospatial neglect, all of which are positive outcomes. Due to the lack of research looking at mirror therapy compared to a particular intervention, it is unclear if there are benefits of choosing this intervention over another evidence-based one. However, no negative effects have been reported. As occupational therapists, this intervention may prove very useful, as it requires minimum equipment, it's inexpensive, and it can be carried out in a variety of settings, from rehabilitation clinics to a person's home. This therapy can also be carried out by an individual in between the visits of the therapist. Overall, the evidence presented here, in particular the Cochrane review and the randomized controlled trial by Tiem et al., are reliable and provide an insight into using mirror therapy as a tool in stroke rehabilitation. More research is required, but the possibilities look bright for the usefulness of this intervention in occupational therapy.